lumbar spine, the entry point is if you draw the midline of the transverse process. This is the classical entry point, and bring it up, and then you draw the line joining the two facets there, and where they meet, you enter, and then you go in. The other entry point which most of the people use is, you see there are ridges here. There's a ridge of the extension of the lateral facet there, and then there's a ridge in the midline which comes here. Where these three these three ridges join is the entry point. If you look carefully, there's a small bump there which is called the mammary process. So that is the entry point. Right? Most of the people use the mammary process as the entry point. Now you can turn around here and you look where the pedicle is. This happens to be right at the center of the pedicle there. So that's what the entry point is. Right? The other thing to notice is, as Juan was trying to say, the lumbar spine has got a curve here like this. So if you look at it, the direction of the pedicles, it is almost straight at L2 and the L3 and then the pedicles start turning downwards, 15 degrees, 20 degrees, 30 degrees. So L5 will be about 25 degrees down caudal, and L3 would be vertical. So when you enter, you go there. So that you have a starter here, or a ronger, or a starter or something. Okay, so you can take a small ronger there and make a notch there, bite it there. And usually you'll see when you make a notch there, you can see the cortical wall around in a flush. Some people call it a pedicular flush. And then you take a probe, or a starter. If you nibble it off, then you don't need a starter. Then you enter there, straight in there, and you can use a hammer. Angulate it, you need to angulate in this direction and this direction, right? So 15 degrees, and you go straight, and you go straight. That will make you an entry there. This is about 10 millimeters. So that's half the pedicle. So you must always sound. Where's the sound? Use this as a sound. Okay. Usually at the tip of there's a sound there. So you go inside and try and feel your walls. So once you are inside, then you find, and then you take your awl. No, not that awl.
This probe.
Yeah, probe. Okay. So you go in, and again the same direction, 10 degrees angle here. At this is L4, and slightly caudal, 10 to 15 degrees. Actually, the best way to judge it, often you don't remember it, is we have the lateral view in front of you. You can see what exactly is your angle there. So you go in about 20 millimeters, and then you would have crossed the pedicle by then. And then what is very important, that you sound your hole, right? So you scratch the medial border. They should be feeling the medial border there. Outer border, superior border, inferior border. If you penetrate the medial border, then you land up in the canal, right? If you penetrate the inferior border, then you land up in the foramina, and the nerve root is there. It's very important to palpate your borders, then further go down classically, and you have some special awls like the Lenke's awl, which let you move around, but by and large it is the preference of the surgeon. And then you again feel for it, and sometimes you can feel the anterior border, and then you measure out the length of the screw, 40, right? So once you measure out the length of the screw, which is 40, then you select your screw. The size of the screw that you see is
640.
Right, 6 millimeter, it's okay. I mean, again, you see the lateral view of the X-rays, and you'll be able to decide what your screw size is. So, in the lumbar spine, 6 millimeter, 6.5 millimeter is a good screw. Now, the other thing is that you got to angle it in slightly, and this is a ratchet here. So you just have to turn half. You don't have to go all around turning, because you land up with a tennis elbow, right? So you gently go half turn, and you'll be able to insert the screw in. It's always better to angle it about 20 degrees inwards. Now, the earlier screw design was made by Steffi, where he would go vertically in, and the entry was more medially at the base of the facet. But Roy Camille type of an entry is slightly angulated in. The pull out of the stem of the screw becomes better. Once, can you have a screw, please? Then the next question is, how deep should you go? Right? If you have more of your threads coming out, the chances of breakage is much more, right? So you should be breaky because of mechanical advantage there. You know, this is not stronger, so your and it will angulate. So the base of the tulip should sit at the bone. Right? If you drive it too much, then the polyaxial screw then will become monoaxial. So just at the base, you should just bend the way. That's the most stable position.
Before we screw it.
The other things, if you get like here now, feel it. Can you feel this? You can't turn it around. Isn't it? Polyaxial screw can be moved around. Yeah, that's the advantage. If you land up into that situation, that means you have driven it too far in which case you have a head adjuster there. Do you have a head adjuster?
Sorry.
The head adjuster?
No.
Or you just take a corpse in and just take half a turn out, and then you'll be able to move it down. See? Yeah. So you'll be able to make the polyaxial. So you must just make that. That gives you an idea. These polyaxial screws have 30 degrees angulation on either side, so you have more No, you're not pushing it in because it's polyaxial. You can't drive it in. For driving it in, you have to lock this. The mechanism is movement here. So what you are doing is moving it like this. It won't go in unless and until you lock that mechanism. Then see, now you won't be able to move it. Then it will go straight inside. So what happens is this goes inside and locks that up inside. Okay. So what I would suggest, each one of you pass the screw, and like I said, it helps you go straight. Okay. Gabriel, will you do the S1, please?
One question.
Yeah.
Before screwing, we need you put the tape before screwing.
Many of these, this is a good question. Many of these are self-tapping screws, in which case you don't need to. But usually most of us tap the entry point only. The cortical area you tap, so about 20 millimeters, and then you pay for the stability. Especially in elderly patients, when there's osteoporosis, then you don't need tapping.